Welcome to our Beyond 20 campaign, a celebration of One Joshua Group's 20 years of service excellence. This is a One Joshua Group production, providing access to information and experts to help improve quality of life and health outcomes.
So thank you for joining us for One Joshua Group's 20th anniversary and beyond. We certainly appreciate your participating in this, and thank you for joining us for this episode. Ask you to review the prior episodes and also those that are forthcoming. Today is a very exciting day. We have joining us Dr. Asa Radix, and Dr. Radix is an infectious disease HIV specialist at the Callen-Lorde Community Center in New York City. And they're also the Associate Professor for Clinical Epidemiology in the Department of Epidemiology at Columbia University Mailman School of Public Health. Dr. Radix is indeed a recognized expert in transgender medicine and has contributed to multiple national and international guidelines for the care of transgender and gender diverse people. Dr. Radix serves on several boards and co-chairs the World Professional Association of Transgender Health, Standards of Care, and their research focuses on STI and HIV risk, HIV prevention, and health outcomes in transgender populations. Dr. Radix, thank you so very much for joining us.
Right. Well, I'm so very happy to be here, and thank you for the invitation.
So the Callen-Lorde Community Center in New York City. Give us some background on that center and what they do about promoting health equity through clinical practice and how they engage the community through their linkages.
Right. So there's a long history to Callen-Lorde, and I want to explain a little bit about it so you kind of understand where we are now. Callen-Lorde's heritage really dates back over 50 years to when we started providing care to the LGBTQ plus communities. There were two initial clinics that were geared towards gay and bisexual men called St. Mark's Clinic and the Gay Men's Health Clinic. And these were volunteer clinics. And you can imagine 50 years ago, this was quite unusual. They were volunteer based and they provided safe and confidential sexual and primary care services. Kind of jump forward to, the 1980s and the, onset of the AIDS epidemic in the United States. Really, this was one of the only places that people could go to get sensitive care. At the time, also, they started providing healthcare to trans and gender diverse people. Actually, Callen-Lorde started one of the first primary care hormone protocols at the time. So these are very, very early days. And over the decades since, we've, really expanded the type of care that we provide. But essentially, we are a community health center, a federally qualified health center with a mission to provide sensitive, quality care and other health services to New York's lesbian, gay, bisexual, transgender, and queer communities in all of their diversity and regardless of ability to pay. And really, to further this mission, Callen-Lorde promotes health education and wellness and advocates for LGBTQ plus health issues. Currently, and I do have some data where we serve close to 18,000 patients. And again, the patients we provide care for are incredibly diverse. Over 45% are people of color. We're a young population. The majority, about 60%, are under age of 40. And about a third of the clients we care for are trans, non-binary, and gender diverse. We actually have one of the I think, the largest cohort of patients who are trans in the United States. So it's well over 4,000, and we have around 5,000 people living with HIV. We also have a very robust HIV prevention services. So, people who are accessing sexual health services and pre-exposure prophylaxis. So um, I think I should also say that, when I'm saying that the folks we care for are quite diverse, that also includes socioeconomic status. So, many of our patients are publicly insured, underinsured, uninsured. Many are undocumented immigrants to the United States, and everyone comes because, they feel well cared for in our institution. So that's a little bit about the history and, where we are right now. Um, I can also share a little bit more about the health services. We are a
Certainly.
primary care center. So, we offer the whole spectrum of primary care services, including, well, I spoke about transgender health, but we also provide um, uh, GYN services, dental health. We have an um, anal health clinic, predominantly for people living with HIV for anal cancer screening, but really anyone with anal health concerns can go to that. We obviously have HIV treatment services, sexual health with pre-exposure prophylaxis as well as post-exposure prophylaxis. Primary care, you can come to us for your diabetes and hypertension and cancer screenings. We have a wonderful clinic for adolescents called HOT, which is Health Outreach to Teens, that cares for uh, adolescents and young adults from 13 to around 22. And we have dental services, behavioral health, and psychiatry. And our newest that you haven't heard about is our COIN clinic, which is our sex worker health clinic. So again, providing care to every population, free of stigma. This is why people come to see us. So those are just a few. I mean, there are other services, obviously, that we have group therapy and so forth. But I'm happy to talk about any of these, in more
So
detail.
we will get around to talking
Mm.
about more of those, but again, to congratulate the center and congratulate you, 50 years. That is a long time to have been in the human rights mission to provide safe spaces for people who need health care. We all need safe spaces to go get health care. So to provide this for 50 years, and then to also be a federally qualified healthcare center where not only are services provided, but the support for those services, like insurance and the other things you mentioned, are also available. But the
Um,
fact that it is safe, you do break down barriers, you look at not just the social drivers of health, but we also understand that the center is involved in issues like housing, assisting with housing. Can you speak to some of that?
yeah, I mean, we provide a lot of wraparound services. I mean, we are a
Mm-hmm.
Brian White center, and we link people to housing, shelter, food banks,
Mm-hmm.
education, legal services. We do provide that full spectrum. I wanted to come back to something you said about safe spaces. About 1 in 5 of the patients that we care for at Callen-Lorde is not a member of the LGBTQ plus
Mm-hmm.
communities. They are straight cisgender folks who come to us because they know they will be seen without judgment. So you're quite right in saying that this care is for everyone. We have people who are our patients who bring their parents in, or they bring their kids in because they know that they will be treated with respect.
Mm-hmm. So I only speak to that because I believe that each of us, if we went to our care provider and we were really safe enough to answer the question when the doctor says, "So what brings you here?" If we felt safe enough to say that, we may have some better health outcomes without judgment, and to be able to share that information with our healthcare provider. Now, you also provide, you mentioned GYN, so you provide a broad spectrum of women's health at Callen-Lorde?
Yeah, so we try not to put a gender on the services that we're offering, right? So, people who are accessing services like cervical screening,
Mm-hmm.
contraception, and so forth. Some of them are cisgender women, some of
Mm-hmm.
them are transgender men, some of them are, non binary people assigned female at birth, some are transgender women. There's a full spectrum of people who will use those services. And we actually don't, I said uh, gynecology just so that you would kind of understand what I'm talking about. We actually call
Mm-hmm.
them gen services, GEN, so that people don't feel discouraged about coming in for
Mm-hmm.
care. For example, for many transgender men and transmasculine folk, the thought of going to a gynecologist, um, could cause a lot of anxiety because
Mm-hmm.
having a male identity and then going to a service that you consider a women's service, that really deters people from care. It's a major barrier to care, just the
Mm-hmm.
title of the service. So we call it Gen Service, and again, it's pretty. It's comprehensive, and it's open to everyone. So, people might go for a breast or chest exam, or for, you know, a cervical pap, or for more conversations about sexual health. Um, we don't, no one is turned away from a service, but we try
Mm-hmm.
and make it welcoming.
So you shared with us earlier that about 45% of your patient population is less than 40 years old.
61% are under the age of 40, so a
Wow,
very
that's
young
even greater.
population, right?
So I asked that question because I have another question. And for the aging population, are there different, so are there gerontological services for that aging population provided specifically for that age group? Do you have those kind of
Yeah.
special
So
services?
this is really an excellent question. So we recently got funded to expand our, elder care services, or care
Mm-hmm.
for older folks, and that includes a medical provider who has a
Mm-hmm.
specialty in caring for older patients, and we're also, as part of that, looking across the board. I think you need to do this anyway, looking at the environment and making
Mm-hmm.
sure that we have everything in place where not only can we be welcoming, but we are serving the needs of the population. For example, just and it's not a just. You need to make sure that when someone comes in, especially if they're older, they may need a little bit more time to navigate the institution. You know, um, they may need time to walk from the waiting room. If they're ambulatory, walking from the waiting room into the exam
Mm-hmm.
room, you have to make sure that the exam room table can move up and down so they can get on it. Not everyone is sprightly and can leap on some of these. Making sure the doors are wide enough for wheelchairs. I mean, there's
Mm-hmm.
so many physical components even before you get to that interaction, um,
Mm-hmm.
that you're having with your provider, and that your provider is knowledgeable about the things that you need. It's even more important when we're talking about, uh, people who identify as LGBTQ plus and aging, because these populations face a lot of isolation. And
Mm-hmm.
many of our older patients they grew up at a time when being queer, being gay or lesbian or trans was really frowned upon. I mean, there was a lot of
Mm-hmm.
stigma back in the day, imagine. And so they carry a lot of that, you know internalized stigma, and it impacts health outcomes.
Mm-hmm.
And on top of it, older, uh, you know, LGBT folks often didn't have the opportunity to have children. Um, so they're also getting older and they maybe don't have younger people to help take care of them,
Mm-hmm.
relatives. They may have been cut off from families, so they don't have people to take care of them. And on top of it, uh, just because of the pervasive discrimination that still happens, but especially when they were uh, young adults, older adults, they could have had their education curtailed. They could have faced
Mm-hmm.
discrimination in the workplace. They don't have that nest egg. So there's so many different issues that you have to take care of. It's not just about aging. It's about aging as an LGBTQ plus person. Um, and no one has advanced planning, but we know from the research that LGBTQ folks are far less prepared um,
Mm-hmm.
in those types of plans.
Well, again, congratulations on the work that you do and also the work at Callen-Lorde. And you kind of led us into this research area around policy and the practice or not around policy. So you'd written about, and help me if I get the title of the article incorrect, Two Steps Back, Rescinding Transgender Health Protection in Risky Times. Tell us about that writing.
Yeah. So, I mean, I've written quite a lot uh, in this area. So I just,
Mhm.
also want to paint a bit of a picture of, you know, what has happened over the last decades. And, um, when and this is specifically around providing care to trans and gender diverse people, and just a little bit of history, uh, you know, um, obviously there always have been people who identify as trans. Like that's, throughout history. You can see that. As far as accessing medical care, um, it was fairly limited until I would say the 1930s, 1940s, when we started having commercial hormone preparations available. For example, testosterone and estrogen. And that was the time when people could start taking medication that would change their appearance. So for transgender women, taking estrogen would have breasts. For transgender men, taking testosterone, their voice would deepen, they would get facial hair. In the 1960s, many centers around the United States started providing gender care in different clinics. So, for example, Johns Hopkins, also, there were places on the West Coast, Minnesota. I mean, there were centers that were set up not only to provide hormonal care. That would fall under endocrinology, but also to provide surgery services. And, uh, it's quite interesting to think that in the 1960s, there were quite a few surgical programs in the United States, and people would be, they were able to access this. And then all of a sudden, in like the late 1960s, early 1970s, there started to be um, a push to close down some of these programs. And there were many reasons why, but a lot of them had to do, especially in the case of Johns Hopkins, with the fact that, you know, there was an expectation that if someone, for example, were a transgender woman, um, that they would be living their life as a woman. They would have what at the time was called a gender appropriate partner. So they would be in a relationship with a man, that they would conduct their life as a woman and leave uh, all knowledge. They wouldn't tell anyone about their trans history, like their past. That was it. So when they did the studies and they realized that that's just not how life works. There were transgender women who were lesbian who would want a female partner and go on with their life. They thought, well, this means that doing surgeries doesn't work. Like we're not actually creating the type of person that we want, which is, it had to do with the time, right?
Mm-hmm.
If you think back to the, late 1960s and early 1970s, this, we had a very different view of sexuality, about gender, and they were incredibly restrictive. So luckily, the decades that followed, after people started having a more awareness and better understanding of things like gender and sexuality, we've started to see more programs, right? Opening up. But now, in the last, I would say, 5 years, maybe 5 to 7 years, again, there have been attacks on this type of care, and it's led by mostly by politicians. It tends to reach a height in election years where the type of care we provide is there are attempts to strip it. So we've gone from having this care covered under Medicaid to having it taken out of Medicaid. For example, in Florida, um, in Texas, they've tried to institute bans on trans health. In Ohio, they have just they're proposing a bill that would basically prevent anyone from accessing transgender health because they're requiring it to be uh, provided only by an endocrinologist, a bioethicist, and a psychiatrist. Right now, most people, first of all, you don't need it, but most people aren't going to have access. I mean, you're saying you need a bioethicist, but that's not covered under insurance. So that's essentially saying no one's going to access. So, when it's constantly evolving, like every day I wake up, I don't know what I'm going to see on the news. It is incredibly disturbing for the patients we care for, and also for the providers because their licenses are in jeopardy in some states.
Mm-hmm.
So that's a lot to say, but this is a really important and troubling area. Um,
Mm-hmm.
that's been happening over the last, as I said, 5 years or so.
Mm-hmm.
Definitely, every year more. I think in the last 2 years there've been something like 200 or maybe 300 attacks on care to
Mm-hmm.
LGBTQ plus folks.
So you mentioned that, and we are, as we in the month of January, we're seeing in the state houses the governor's announcements about their budgets and their programs. Um, we are Georgia based, so we hear a lot of some of that same information here. But it's critically important that we continue to talk about policy to advise individuals how they can be involved in advocacy for better health care generally, and particularly for the populations transgender, LGBTQI plus, and others who may have a different perspective where the issue of safety and care and interest are important. I wanted to take you to something that we've recently been involved in other programs, and you um, were included in the team study, Together Equitable, Accessible, and Meaningful Training to Improve Cancer Care for Sexual and Gender Minorities. You want to share some information with us about that particular pilot study?
Right. So I've been involved in only a very small part of this, and
Mm-hmm.
I'll say in general, what we're trying to do is improve knowledge, skills, and attitudes of providers, so that they can work with clients. I mean, all clients, but understanding what their specific needs are, how to talk to people, how to provide accurate information, um, how to engender trust. I mean, there's so many different components of this, and I'll say, when you made the point that we all need care, just understanding that if we elevate care for one population, we elevate care for
For them all.
everybody,
We do.
you know, and it's and also, you don't know what you don't know. I think there are many providers who feel that, oh, like I know it all, but they don't know it all. They're definitely, as I said, it's knowledge, skills, and attitudes. So, they may have an attitude that, patients may not feel comfortable
Mhm.
being in their clinic. That may be a barrier to care. Providers' lack of knowledge about how to counsel someone, for example, who is on testosterone and has a cervix, that can lead to poor outcomes if they're not
Mhm.
knowledgeable about it. So it's every step of the cancer care continuum, right? So it's talking about prevention, getting people in for screening, um, uh, ensuring that people have the right nutrition, diet and exercise. That and it's not just about cancer. I mean, it's also, if we think holistically, thinking about cardiovascular risk, all the other things that you should be thinking of as a primary care provider. But just understanding all the areas in the cancer care continuum where people may fall short. So again,
Mhm.
prevention, treatment, like how does treatment differ? If you have someone who is getting a cancer treatment and you adjust the cancer treatment, say chemotherapy, based on their kidney function, but we know kidney function can change when you're on certain hormones, then
Mhm.
how do you adjust that? And all the way to um, survivorship, like, what do you need to do to care for people in that situation, and also end of life care. So again, it's
Mhm.
like the full spectrum.
So I had another question, but you kind of answered it. And my question was, when we look at the continuum of care around cancer, you've mentioned cardiovascular disease, and you really said that a lot of these concerns apply to cardiovascular and other disease states. So I won't ask you that question because I do recognize that cancer probably is a good place to start, just because of the opportunities for us to be able to discuss that continuum. Again, we've been joined by Dr. Asa Radix, um, who is an expert in transgender medicine and is involved with Columbia University's Mailman School of Public Health, and also involved at the Callen-Lorde 50-year-old plus service provisions for the LGBTQI plus community. Now, Dr. Radix, lastly, when we looked at the areas around community engagement and this community health center, we understand it has a community advisory board. What is the role of the community advisory board at Callen-Lorde, and how important is that advisory board to supporting the center and its patients for improving their health outcomes, or just providing healthcare services?
Well, we have more than one community advisory board. I should say that as well. We have for youth, we have for the center as a whole, we have a cab for our research team. They are key to every program that we start. They are key to patient satisfaction. They are key to alerting us to concerns. They provide feedback on everything that we do. And and they're not shy to tell us when we don't get it right. And I think that is so important. We just had, I'll give you just an example of the research cab, and an initiative that we brought to them just a few weeks ago. So it's fresh in my mind. And this was about doing a specific project to evaluate the changes in the vaginal microbiome. So we're looking at changes in, bacteria and
Mhm.
changes in pH and so forth in people who are taking hormones. And, we were able to go to the cab with this and ask really key questions like, is this a community concern? Like, do you rate this? Because, we don't want to do research that no one thinks is important. We think it's important as researchers, but what does the community think? And also, um, what do they think about the potential outcomes of the study, and how do they think we should, create materials? And I mean, it was wonderful because, the cab, people who were on the cab who were potentially eligible was saying, wow, like, this is really important to us. This is something that no one has ever asked us about, but this is an issue that has, bothered so many because the symptoms associated with changes in the microbiome, dysbiosis, can cause, pain, discomfort, can cause discharge, can cause, problems. But they were like, no one's ever asked us about this. Like, we
Mm-hmm.
think this is super important. Um, and then provided us with some additional thoughts that we should include into the study. So, you know I mean, and I'm just saying like one small part, but the cab has also been involved in our sex worker clinic. They're involved in our youth services. They're involved in how we provide HIV services, how we, every single part. And uh, they really frame so much of what we do.
Mm-hmm.
You know?
So we appreciate that, and as you mentioned in Callen-Lorde, the cab is such an important part in getting feedback and just a way to be able to give additional information back to Callen-Lorde. And Dr. Radix, we just thank you so very much for sharing that insight and the experience at Callen-Lorde and what you do relative to research. So, in closing, what would be your recommendation for takeaway to our viewing, listening audience um, about promoting health equity and clinical practice and community linkages, particularly in the LGBTQI plus and the transgender population?
Yeah. I mean, I think, every center, every clinic, every entity that's providing health services or, other services to people, first look at the populations that you're serving, because it's
Mm-hmm.
going to differ. Like Callen-Lorde works great in New York City. Maybe if we moved to Georgia, we wouldn't work as well, right? With the like current programming that we've prioritized. So you need to look at the population you're serving, find out from them what the priorities are, find out from them what services they're asking for, right? Um, and tailor your programming to that. You initially you asked about uh, folks who are older. Maybe telehealth isn't an option that older people might want, but you don't know unless you ask, right? So you need
Mm-hmm.
to find out. Ensure that there's community input from day one on everything. Otherwise, you're just not going to get it right. And also, I think lastly, it's not just about instituting the programs. It's also, the implementation is also about
Mm-hmm.
figuring out if they're successful or not. So you have to develop the metrics to make that determination. And you need to be willing to uh, go back to the drawing board if it's not working. So I would say flexibility and humility are definitely qualities that um, people need to have, and a good sense of humor to make sure that you can get the programming correct.
So, Dr. Radix, thank you again so very much. You've been enjoying and having been informed by Dr. Asa Radix, who is an infectious disease and HIV specialist at the Callen-Lorde Community Center in New York City, and also an associate professor of clinical epidemiology at Columbia University. Um, Thank you for telling us about humility. Thank you for telling us about humor. And thank each of you for joining us as we celebrate our 20th anniversary and beyond. And again, thank you, Dr. Radix, for helping us broaden our horizons. And hopefully, what we say here at One Joshua Group, to remember to be kind, uh, to be thoughtful, and also be considerate. Join us for our next episodes. And thank you again for joining us today. Thank you again, Dr. Radix.
Oh, well, thank you for having me.
This edition of Beyond 20 is a Life Beat podcast sponsored by One Joshua Group. your strategic source of engagement to improve life through better health, education, and information. For more information, visit us at theonejoshuagroup.com or follow our work on LinkedIn, Facebook, Instagram, and Twitter using hashtag OneJGCollabs. One Joshua Group, building capacity, expanding resources, joining what you know with what we've learned.